This is my patient today, Sally. She is a 10-month-old female beagle mix presenting for spay, and she's 25 pounds. And today for her pre-med, she's going to be getting acepromazine, atropine, and buprenorphine, and these are my calculations. And then she's going to be getting, for her induction, propofol. For her post-op meds, she's going to be getting Onsior injection sub-Q. And then her fluid rate I have down here. So as we come over here to my anesthesia machine, I would be deciding if I'm using a rebreather or a non-rebreather system. And since this patient is larger than 15 pounds, I'm going to be using the rebreather system. So I would have to get my bag. I chose a 1-liter bag because my patient, when I did the calculations, came out to be 600 mLs. So I had to round that up to a 1-liter bag. And then I would be choosing next my tubing system, and I'm going to choose the universal F system. So I'm going to attach that to the correct unidirectional valves. I'm going to be putting the inspiratory and the expiratory on those, and then I'm going to start by checking my flow meter here. So I'm going to leave the pop-off valve open, and I'm just going to turn that up to 1.5 liters per minute, just to make sure that the ball is staying steady, that it's not rising or falling. And then I can turn that off. Then I can next check my bag, make sure it's not leaking, make sure there's no holes in it. I'm going to close my pop-off valve. I'm going to put my finger through the end of the tubing system, and I'm going to press the O2 flush until my bag expands and my pressure manometer system gets up to about 30 centimeters of water. And then I'm going to make sure that the bag isn't deflating, that the manometer isn't decreasing, and if it is not, then I know that that bag is okay to use for this procedure. I'm next going to check my scavenger system to make sure it's working properly and that all of the expired gas and CO2 is getting out and that it's not going into the patient's lungs. So I'm going to open up my pop-off valve, and then I'm going to put my finger over the end of the tubing system, and I'm going to turn my flow meter all the way up so that the oxygen's running through, and if the pressure manometer doesn't increase any, then I know that it's going through properly, there's no leaks there. Then I can next check my vaporizer, make sure there's enough ISO in there for the procedure, make sure it's at least halfway. And then I can check my CO2 canister, make sure there is no blue or purple particles because that would mean that it's expired. And then I can also open it up and take out some of the crystals, and if they crush easily, then I know it's not expired. If they're hard to crush, then I have to discard it. So as the GCN, I am going to have all of my catheter supplies out. So I have my tape, I have notches on all of them. I have my alcohol and my scrub here. I have my catheter. I would have an injection port here. I have my clippers. I have my propofol for my induction. I have it labeled. I have my flush. I have my endotracheal tube. And then as the SA, I would have the surgery pack. I want that in the OR on the Mayo stand for the surgeon. And I have a 2-aught PDS suture because I know my surgeon's partial to that, so I'll have that in the OR so that the GCN can open that up sterilely for the surgeon after the pack is opened. And then also as the SA, I would have my gown and my surgeon's gown out all set up. I would have our masks out for us so we can put that on before we scrub in. And then the GCN would be tying us in so that we can come in and that we're all sterile. So then now I'm going to start prepping my patient. So we're placing a lateral saphenous catheter in her today. So I would have my restrainer just restrain her for me, and she's sedated now, so she should handle this better than if she wasn't. But I am going to find my vein, and then I'm going to grab my clippers and I'm going to start clipping. And then I'm going to start with scrub, alcohol, scrub, alcohol, and then one more scrub and one more alcohol. And then I'm going to grab my catheter. I'm going to find my vein. I'm going to insert my catheter, and then I'm going to take out the needle, and then I'm going to place in the injection port, and then I'm going to start taping in my catheter. So I'm putting a smaller piece first, just to keep it in right, and then I'm going to use a notch next to stabilize it even more. And then I could use this last piece if I wanted to, just to make sure that my catheter stays in properly. And then I'm going to grab my flush next. And I'm going to insert, aspirate slightly, make sure I'm getting blood so that I know that I'm in. And I could also feel the vein up here as I'm inserting the flush to make sure that I feel it going through the actual vein. And then next I'm going to be inducing her with my propofol. So I'm just going to insert that, and I can start adding the propofol very slowly so that my patient doesn't get apneic. And then I can keep that in there, and then I can come over here and check her eyes, see if I'm still getting a blink reflex. I can check my jaw tone. I can see if her eyes are starting to go down and out, which is how we want them for surgery. She'd be in stage 3, plane 2 for surgery. And then I'm gonna give the rest of my propofol. And then I would turn her to the front with the help of an assistant. And then my assistant is going to open up the mouth for me. I'm gonna hold my endotracheal tube like this. The mouth's gonna be open. I'm gonna hold the tongue out with gauze, and I'm gonna insert my tube into the epiglottis, and I'm gonna be looking for the laryngeal folds opening and closing. Once they're open, then I can insert, I can inflate my cuff, and then I would tie this around her head, and then we can start scrubbing her and getting her prepped for surgery. So I would turn her over to her back, attach her to the anesthesia machine. I would turn her oxygen on first, then I would turn her ISO. I'm gonna have the oxygen set at 1.5 milliliters, or sorry, 1.5 liters per minute, and then I would turn her ISO up to 1.5 to start out, and then we'll see how that goes for this procedure. My anesthetist is going to start recording everything, and I'm going to start prepping her as the general circulating nurse. So I want to go from, especially since it's the spay, I want to go from her xiphoid process down her pubic symphysis. I'm going to feel that, and then I'm going to start clipping, and I want to go 2 clipper blades width on each side of the incision site. And I want to make sure I'm going flat with the clipper so that I don't nick her skin or anything. And then I'm going to do 3 scrubs, Chlorhex alcohol outside of the OR, and I'm doing a circular pattern, the target pattern. I'm going dirty in and bringing that away. I'm going to do a dirty scrub out here first, and then once I get into the OR, I'll do my final scrub. So I would do that 3 times, and then I would bring her into the OR. I would put gloves on for the clean scrub. I would do the circular target pattern. I would do that 3 times. Then I would put some betadine spray on there, and right once I am done doing the dirty scrub, I'm gonna detach her from the anesthesia machine, carry her into the OR, hook her right up again. The anesthetist would, and then I would start doing my clean scrub for her. To perform jugular venipuncture under anesthesia, my patient's legs will already be tied back. Same with the back legs. I am just going to come up here, find my thoracic inlet and occlude, and then with my thumb, and then my pointer finger is going to extend the neck up. And then I am going to find my vein from the occlusion. It should be bouncy and rubber band-like. And then I'm going to take some alcohol and just wipe it. I'm going to insert my needle bevel up, basically parallel to the vein, because you don't want to go too deep. And then I'm going to aspirate back, pull my plunger, and then if I get blood, I can continue to aspirate to get however much blood I need. But if I don't get any blood on my first try, I can pull back and redirect a little bit and then continue to aspirate and get blood. And then once I have gotten the amount that I need, I'm going to let up my occlusion, put my finger over the needle and pull the needle out, and then just hold that for a couple seconds so that the blood can clot. The surgery has lasted 30 minutes, the surgeon is done, and our patient right now, our anesthetist, is going to take her off of gas anesthesia, and she's going to leave her on oxygen for the next 5 minutes to flush out the anesthesia and help her recover. And as the GCN or SA, we are going to take out all of the instruments that were used by the surgeon. We're going to take off the drapes from the patient, and we're going to clean the instruments. And then the patient, we are going to put some hydrogen peroxide and just wipe off the blood from the incision area. And once the anesthesiologist is continuing to monitor for these next 5 minutes, the general circulating nurse and the surgical assistant will continue to clean everything so that they help the anesthetist and they can be ready. And they will also be getting her recovery cage set up for her. They're going to put some blankets in there for her to keep her warm because her temperature is at 99.5 now. So we just want to keep it up there. We don't want it to go any lower. So they're going to get that set up. And then the anesthetist, her post-op plan would be to keep her on oxygen for 5 minutes, as I said. And then once the 5 minutes is up, she will wait for the 3 swallows, and then she can deflate the cuff of the endotracheal tube, and she can extubate and then carry the patient to the recovery cage, where she will just set her up in her bedding. She won't give her food or water until later because she needs to make sure that she's fully awoken before the patient can start eating or drinking again, so there's no risk of aspiration. And the next 3 days, the anesthetist or the surgical assistant will come back and monitor the incision site, make sure there's no redness, swelling, oozing, discharge, bleeding. And if there is, they can relay that back to the vet, the surgeon. This is my anesthesia log. I have everything filled out, the drugs, the concentrations that I gave, the dosages. I have all of her PE information, that she was ready for anesthesia. I have the amount of fluids that we gave since it was a 30-minute procedure. I have the oxygen, flow rate, the bag that I used. We used isoflurane. And then I have my initials and what her post-op temp was, the time that I extubated, and the time which she was sternal.